So chemo-immunotherapy has become the gold standard, CIT, for treating CLL in certain subsets. But there's a lot of controversy, and I've talked with other physicians on this that have come down on very different points about where this is, and it looks like where it used to be kind of for everyone, now it's that the group that should be treated is shrinking a little bit. And I just wonder where you see it fitting in and how you see that. Obviously it's a changing, whatever you say today could be different in 6 months from now, but how do you see that picture evolving?
So, as you said, for young and old patients with first-line need of treatment, chemo-immunotherapy might be still the treatment of choice. And I say this because we have now several trials for the young and old that the addition of an antibody against CD20 is improving the outcome. The major question for this is how intense has the chemotherapy backbone to be, so FC versus B versus even granulocyte or something like that. So that's question number one. The second question is whether there are some patients who are not benefiting at all from this treatment because they are poorly responding or not having a long-term remission. And that's probably some high-risk patients that are resistant to chemotherapy or have a sort of fast relapse rate. And that's high-risk patients that probably can be treated today if they have unfit with kinase inhibitors if available. Some of the kinase inhibitors and the BCL2 antagonists that we discussed are impressively active in these patients. So we come to a molecularly or genetically defined distinction where we would say a patient that is mutated, immunoglobulin heavy chain genes are mutated, good risk, has a certain number of deletions, like either deletion 13q or 11q or trisomy 12, combined with mutated IDH complex. Those are the good risk patients, and chemo-immunotherapy is probably the best choice that we presently have as a first-line treatment. For the remaining patients...
Let me just stop you there. I just want to tease that out. The 11q, that's only the mutated group of the 11q, not the unmutated group.
We don't know that for sure, but you're right. I mean, it seems that the deletion 11q patients are benefiting in general. It's actually the group that benefits the most. But here we are talking about a new finding that came up at this meeting, and that is how can we eventually identify the group that has remissions of longer than 10 years with any therapy. And it seems that a combination of mutated immunoglobulins plus any of the good risk chromosomal aberrations, and I repeat because that's new, deletion 11q, trisomy 12, and deletion 13q, those combinations might have a long-lasting remission after a single chemoimmunotherapy composed of FCR. So 6 months treatment, but then 9 to 10 years, no relapse in many, many patients. And if that is true, then we see the opposite, that is no karyotype anomaly of this type or deletion 17p. And those patients probably need to go into treatments with the novel agents because we need to strongly improve their outcome. They are not doing so well, and we may be able to predict that from the very beginning. And that's actually an interesting new hypothesis that comes up from this meeting. If we talk about relapse, the situation is entirely different. I think here there's lots of uncertainty, and I'm expecting in the near future many of our patients at relapse will be treated with kinase inhibitors and BCL2 antagonists as soon as these agents become available.
So let's pause here for a minute and we'll pick it up again in a second.